So hello everybody, I hope most of you will know who I am. I'm Helen Cross. I'm the Prince of Wales Chair of Childhood Epilepsy and Paediatric Neurologist in London, UK. I'm also currently the Treasurer and President-elect of the International League Against Epilepsy. It's my delight tonight to talk about ketogenic diet therapies in the epilepsies, and happy to take any questions following the presentation. It's a delight to talk to you this afternoon on ketogenic diet therapies, specifically in the treatment of the epilepsies. These are my disclosures. So, as we talk about ketogenic diet therapies, I'm going to cover several areas over the next 30 minutes or so. What is it specifically? Does it work? And looking at the alternative forms of the ketogenic diet that we may utilize. The practicalities of implementation. Barriers to implementation. Can we predict who may respond? In whom should it be considered? Can we implement it across the lifespan? And where are we going from here? So the ketogenic diet, a high-fat diet designed to mimic the metabolic effects of starvation, used in the treatment of epilepsy for almost 100 years. Next year, 2021, does see 100 years since the publication of Wilder's initial 3 cases utilizing a high-fat diet to mimic the effects of starvation, generating ketonemia in the treatment of epilepsy, with later publications of large cohorts of patients where the ketogenic diet was utilized. However, it is not a natural treatment. Many patients come to us wanting to utilize the diet because they see it as a natural treatment. It's utilizing natural products, but on implementation, it needs to be monitored as it has side effects, just like any other anti-seizure medication. We now have randomized controlled trials demonstrating efficacy, specifically in drug-resistant epilepsy in children. The graph on the left shows the results of our randomized controlled trial, where children between the ages of 2 and 16 were recruited with continuing seizures, despite at least 2, although in many cases many more, anti-epileptic medications. And they were randomized to either receive a ketogenic diet or no change in treatment over a 3-month period. And you can see that there was a significant reduction in the ketogenic diet treated group over a 3-month period compared to baseline, and also compared to no change in treatment. On the right is a study then was subsequently published from India using similar methodology, but again in children aged 2 to 14, continuing seizures despite anti-epileptic medication, utilizing a modified ketogenic diet, formerly an Atkins diet, where it is high fat, but low carbohydrate and unlimited protein. This demonstrated similarly that there was a significant reduction in seizures from baseline compared to no change in treatment in the ketogenic diet therapy group. And now if we look at the most recent Cochrane review, where they determined 13 randomized controlled trials in 17 publications. Admittedly, some of these randomized trials look at methods of implementation, such as randomization to fasting versus not fasting at initiation, or indeed hospitalization versus non-hospitalization. But for the first time in this Cochrane review published this year, you could see that actually there were 4 studies that could be utilized in a meta-analysis, giving a total number of those on the diet of 193 and those of 192 who had usual care or no change in treatment, and showing that there was a definite favoring of the ketogenic diet in treatment with effect over and above no change in treatment. So now we know also that we have a range of different ways to administer the diet. The classical diet, as was originally put forward in the 1920s, was a high-fat, low-carbohydrate, low-protein diet. And indeed, where the majority of fat came from long-chain fats, and the ratio of fat to carbohydrate, including protein, was 4 or 3 to 1. It was in the early 1970s that Hunter Locker put forward that as this diet was perhaps quite unpalatable with a lot of side effects, perhaps using medium chain fat, where medium chain triglycerides generate more ketones per calorie than long chain fat, we could utilizing MCT in the diet, we could actually perhaps free it to some degree with regard to protein and carbohydrate, although it was still a low carbohydrate diet. And indeed, the MCT diet was born. We now also have the modified ketogenic diet therapy, where there's unlimited protein and low carbohydrate. And we also have put forward the low glycemic index therapy, looking at complexity of sugars that may be digested. This having been put forward and shown to be effective by the group at Mass General in Boston. And we know if we look at the different therapies, there may be a different degree of ketosis, and also the different therapies may be tailored to the age group that we're trying to treat. So for example, in the infant and even the preschool child, where they can monitor what they eat quite carefully, then the classical diet may be the way to go forward, and certainly you get the higher degree of ketosis with the classical diet. An MCT diet may be more appropriate in the older child, maybe of school age, and even of the adolescent, whereas the modified ketogenic therapy may have a much greater degree of compliance in the much older, including adolescent and adult, or even the low glycemic index therapy. And we now know that the diet can be administered in many countries of the world, implying that we can utilize the diet in many different cultures of the world. And which diet is utilized, again, may depend on what is the main base of the diet. For example, if rice or pasta may be a main base of the diet in that particular culture, then maybe the MCT or the modified ketogenic diet therapy may be easier. Whereas in cultures where there may need to be a degree of reimbursement for therapies, then the classical ketogenic diet therapy may be a way forward. So what about implementation? Well, in 2009, Eric Grossoff brought together a group of pediatric neurologists and dietitians and nutritionists in order to try and come up with some recommendations with regard to implementation of the ketogenic diet. And indeed, it was recognized at the time that we couldn't generate enough data, or enough data hadn't been generated to give formal guidance, but certainly recommendations could be made on the basis of the literature and indeed consensus opinion. And these were originally published, as I said, in 2009, and then updated, published, as outlined here, in 2018. There have also, as a result of working with the International League Against Epilepsy, determined minimal requirements for ketogenic diet services in resource-limited regions, accepting we don't have full resource everywhere. These papers deal with issues such as patient selection, in whom should we be deciding on, and indeed what should be considered in pre-diet evaluation and counselling, and also on diet selection dependent on the presentation of the individual and perhaps the usual dietary basis or what is in the usual diet of that individual. There is also then guidance or recommendations with regard to diet provision and initiation, and particularly with regard to the fact that there will need to be an individual calculation based on the calorie intake of that individual on a usual day-to-day basis. Recommendations about concurrent anti-epileptic drugs. We don't have any significant evidence to suggest there being pharmacodynamic interactions between the diet and conventional anti-epileptic drugs. However, we do need to be aware of possible similar side effects with certain drugs used in conjunction with the ketogenic diet, such as zonisamide, topiramate, where there is also a degree of carbonic anhydrase inhibition and indeed a tendency to acidosis. In our experience now with more frequent use of cannabidiol, I have seen an increased ketosis in these individuals, so we may need to tailor the diet accordingly. And there is also some concern perhaps about valproate. Could this be contraindicated in the diet? And certainly this may need to be met on an individual basis, by individual, case-by-case basis. Although in my experience, sometimes if they're on the valproate, albeit it may affect ketosis, but also weaning of valproate ultimately may enhance effect of the diet, although this is anecdotal. What about supplementation? Well, on the basis of the recommendations, yes, there needs to be multivitamin and mineral supplementation and adequate vitamin D for that individual. There's no evidence for empiric use of antacids, laxatives, or indeed carnitine, and no consensus on empiric use of citrates, although many of us would think that, as I'll come to in a minute, that very young non-ambulant individuals probably do justify prophylactic use of citrates. And it is widely accepted that there needs to be regular monitoring of individuals who remain on the ketogenic diet. Of course, that may be daily with regard to the family, checking on ketosis. Many centres now utilise blood ketones, utilising meters and strips, although some families still prefer to utilise urine analysis. There needs to be ongoing contact with the diet team, review by the multidisciplinary team at 1, 3, 6, 9 and 12 months over the first year of utilisation of the diet, and each visit's checking on the nutritional content of the diet, laboratory investigations, anti-seizure, anti-epileptic medication use, and ketogenic diet therapy duration review, namely, do we still need to utilise the diet, or should we be considering a wean? And indeed, this was never been thought to be a lifelong treatment. Certainly we would review benefit over a 3-month period in the first instance. If no benefit seen, then consideration of withdrawal at that point. But if it is effective, consideration given as to when ultimately we will trial a further wean, perhaps at 2 years. And 80% of the individuals, if there's been a benefit, then we are able to wean the diet. But in a small number, it may need to be continued. And at each evaluation, there needs to be a consideration of the risk benefit to continuing the diet. So what about barriers to implementation? Well, there are many different barriers, or even things we need to consider on deciding whether a ketogenic diet therapy is the right way to move forward. There is still a widespread physician perception of poor palatability and the difficulties of implementing the ketogenic diet. There is a constant request for data as to what the relative benefit is relative to other anti-epileptic drugs, but you could argue, particularly in the very young, we don't have much in the way of data with regard to anti-epileptic drugs and treatment of different epilepsy syndromes. There is also a perception about the safety and the worry about side effects. And also where diagnosis may be unclear, what are the risks of initiating a diet if there is a metabolic derangement? There are also various perceptions on the part of the family, perhaps less so now with the internet and discussion over the internet, but there is concern about restriction of the diet, the practicality of how you administer it, the implications for the family and the family dynamics, the palatability to the child, and the possibility of adverse effects. And of course, there is a resource required. This is not something we could just prescribe. It needs to be carefully calculated and monitored by a ketogenic diet team, not least the dietitian. There are, of course, various metabolic contraindications to administering a ketogenic diet, primarily those conditions where glucose really is required for continued maintenance of metabolic stability. And certainly beta oxidation defects, pyruvate carboxylase deficiency are 2 of these metabolic problems, and these need to be ruled out prior to commencing a ketogenic diet. And there is also the concern about side effects. What side effects may we expect? And certainly we cannot ignore the fact that side effects may occur, as I said at the beginning. This is a treatment by which you may use natural products, but it is not a natural diet. Certainly, there is a worry about metabolic abnormalities, but these are usually very minor, particularly if we've ruled out those metabolic defects where there's a contraindication. The most common side effects are gastrointestinal, and the majority of which will be alleviated with dietary modification. Renal calculi do occur in 3 to 7%. And usually we can treat with utilization of citrates, and it rarely requires diet discontinuation, but we do need to monitor for this. There is concerns about growth, particularly in the small children. And this is the main longer term side effects. There are minimal data on long-term effects, as I said, as many of these individuals who trial the diet, even with benefit, come off the diet after a short term. When we did our randomized controlled trial, actually comparing not only the ketogenic diet therapy versus no change in treatment, but when in the ketogenic diet group, they were also randomized to receive either an MCT or a classical diet. And we found very little difference in the degree of side effects that were actually seen. Vomiting occurred a little more in the classical diet. Lack of energy, again, a little more in the classical diet. It's difficult to quantify these. The reports were of any vomiting, so even a vomiting once would have been reported. Most of the symptoms could actually, or the side effects could be alleviated with dietary modification. On further evaluation of who may be at risk of renal stones, this study from the Johns Hopkins Hospital showed that those who are very young and indeed who have a demonstrated hypocalciuria are those more at risk to develop renal stones. So this where children, perhaps under the age of 3, we would consider citrate prophylaxis in those on a classical ketogenic diet. And with regard to growth, what is found is that actually growth is slowed whilst on the diet. And it's more obvious the younger the child. The Z scores deviating away from the norm to a greater degree, the younger the diet has been initiated. That aside, once they stop the diet, there is growth catch-up. This doesn't appear to be related to protein intake, possibly related to the mild acidosis and the effect on bone growth that this may have. But certainly once they wean the diet, then there does appear to be catch-up growth, and they don't stop growing altogether. And the other concern, particularly when we're trialing this diet in the older individual or even the adult, is the derangement of lipids and lipid profiles. And you can see from this study from Mackenzie Cervenka and colleagues is that yes, about 20 to 30% may show a derangement of lipid profile. And although we find in the children that these may, after the initial 3 months, may then subsequently normalize. The consequences of a deranged lipid profile in children is unclear in the longer term, and particularly when you trial the diet for a specified period of time. But the study on the right did look at endothelial function, looking at arterial wall distensibility, and demonstrated that with higher cholesterols, there was a degree of stiffness of the arterial walls, and this could imply there was a risk of longer-term vascular problems. But of course, when we suggest initiating the diet, it is quite an onerous burden on the families, and they do have to think about how they manage to do that. And certainly, I think many of the families and mothers particularly, yes, some fathers are those that cook, may feel they're juggling everything, and having to implement a special diet in one child may be an additional burden. Originally, and looking at a classical diet, then it may have been seen to be pretty boring, pretty unpalatable. How can you, if you're given specific calculations, how can you make that palatable for the child? But I think with the help of many different organizations, now not least Matthew's Friends, as an example, Charlie Foundation, and many numerous cookery books, then actually the diet can be made very varied and indeed highly palatable. Interestingly, Natasha Schuller, who works with me at UCL, looked at an attitudes to medicine questionnaire and adapted it to implement in a series of families who had started the ketogenic diet in one of their children. and demonstrated that if there actually was a high necessity score, so the family perceived that the treatment was required, then they were more likely to have a child who responded to the diet. Whereas if the concern score was high, namely that they had a high degree of skepticism with regard to the diet, then they were less likely to have a child who would respond to the diet. Showing perhaps there does need to be a degree of commitment and that belief that this diet is required in order to ensure success. But do we have further information about in whom the diet is best used? Is there a degree of epilepsy syndrome specific efficacy? We could argue that we need to consider the diet in any child with ongoing seizures who has failed 2 anti-epileptic drugs or 2 anti-seizure medicines. But can we have any handle on who is more likely to respond? Certainly, there is an increasing number of metabolic diseases in which reports of benefit of the ketogenic diet have been demonstrated. Of course, there are metabolic diseases where we are looking at the underlying problem and perhaps targeting that, not least providing an alternative fuel for the brain over and above the glucose that cannot be taken up, whether that be GLUC1 deficiency or indeed pyruvate dehydrogenase deficiency. But whereas previously it was felt that perhaps in mitochondrial disorders that may be contraindicated, we now realize that benefit can be demonstrated and there is mechanistic action that may be show why that is the case. And also some degree of benefit has been shown in glycogen storage disorders. And there are a range of other metabolic diseases where symptoms have been treated successfully with the ketogenic diet, as shown on the right. With regard to epilepsy syndromes, there has been benefit demonstrated in spasms, whether newly diagnosed or indeed drug resistant to standard therapy. Dravet syndrome, again, compared to what we consider suboptimal treatment without stiripentol or indeed following optimal treatment with stiripentol, clobazam and sodium valproate. Lennox-Gastaut syndrome, this showing that can still see similar numbers of portions of benefit, even though there may be a multitude of different causes here. And epilepsy with myoclonic atonic seizures has been shown to have a very specific responsiveness, perhaps more of a response to the ketogenic diet over and above other standard anti-epileptic medications, and even a suggestion from one study about early use being associated with improved cognitive outcome. There is a report from the Australian group of suggesting that actually in a proportion of those that respond promptly, they may have an underlying glucose transporter defect. However, this does not appear to be the total story, and therefore it's still recognised that this group of patients show particular response to the ketogenic diet, but there doesn't appear at the present time to be a mechanistic action that can explain this for all. Of course, that comes down to the other aspect, and namely, how is the diet working? And of course, I think this is we've had a multitude of different actions that have been put forward. But let's look at the classification framework of the epilepsies to see if we can get further insight as to who may or may not respond. Certainly, the etiology or the cause of the epilepsy is gaining is becoming more important, particularly in the more complex epilepsies, responsible, of course, not only for the seizures, but also the comorbidities that may be seen alongside that. And of course, the glucose transporter defects falling into the genetic etiology, an example where we're targeting the etiology with the ketogenic diet in order to gain improvements. GLUT1, one of 9 glucose transporters coded for by the SLC2A1 gene. And of course, we know that this can present in a wide range of different ways. We can have the early neonatal form with the poor prognosis with regard to neurodevelopmental outcomes, seizures in the longer term. There's early onset absence epilepsy, other types of epilepsy, and also later onset movement disorders. Recognizing that glucose cannot be taken up into the brain, treatment with a ketogenic diet reducing ketones could be seen as a treatment of choice here. And certainly in the study, looking at response to the ketogenic diet, 86% of those with epilepsy as a clinical manifestation appeared to respond. And there is also some data now to suggest that the earlier we diagnose this and treat with a ketogenic diet, it's not just the seizures we're treating, but we also are improving cognitive outcome longer term. What about other genetic disorders? Can we see any other genetic basis to a response to the ketogenic diet? Well, thinking that maybe many of those that are dramatic responders may be undiagnosed diagnosed cases of GLUT1. Natasha Schuller again evaluated 246 cases and actually only found one new case of SLC2A1 mutation in that cohort. So again, this isn't the whole explanation for a response. She also looked at some candidate genes with regard to reviewing a possible response, such as KCNJ11 or in BAD, but did not find any significant association with these genes with regard to response. We do, however, know that in structural epilepsies, however, particularly beneficial response may be seen. The study on the left showing a particular response of the ketogenic diet to the ketogenic diet in individuals with focal malformations of cortical development, showing that almost 50% at 3 months from treatment of the ketogenic diet were indeed seizure-free, and that 20% demonstrated long-term seizure freedom at follow-up, even on weaning of the diet. And then a small study on the right showing that the children with post-acquired structural injury epilepsy also showed a particular beneficial response on collated data. Randomized controlled trials have predominantly involved children in the mid-age range, 2 to 16, 2 to 14. What about the very young population, or indeed adolescents and adults? Well, there's long been a belief that infants may respond particularly well, and our data in anti-epileptic drugs per se traditionally have not been great with regard to epilepsy onset in the first 2 years of life. These two open label studies demonstrating particular benefit in infants that maybe seem to be higher than in the degree of responders than we may see in older children. We are currently conducting a randomized controlled trial of children under the age of 2 with epilepsy and continuing seizures despite treatment with 2 anti-epileptic drugs. So this includes spasms who have not responded to vigabatrin and steroids. And this has been a slow study to recruit to, not an easy study to perform, at least the perception that children of this age need rapid changes in their anti-epileptic treatment, the need to control seizures, difficulties in achieving a baseline, or even the relatively late coming to the study after a trial of 4, 5, 6 medications, and therefore a belief that the ketogenic diet is the way to go, and therefore the lack of possibility to randomize. But at the present time, we are randomizing. Dropouts are relatively small. And now, earlier in the year, we've got up to patient 113. Unfortunately, COVID has put a pause on our recruitment. We're just about to start again. And hopefully we will get to 120, 105 patients to give us 80% power. This looking at ketogenic diet versus the next suitable anti-epileptic drug. However, there is also some evidence in this study from Austria looking at the utilization of ketogenic diet and looking at the differential across the age range and suggesting that actually the earlier we use the diet in the management of the epilepsy, the more likely there will be a response. Certainly showing they divided it into 2 groups, Group A, where the diet was initiated under the age of 18 months, and Group B, where they were over the age of 18 months. And you can see they were more likely to be seizure-free at 3 and 6 months if the diet was initiated under the age of 18 months. And also there was a likelihood of longer-term seizure freedom. And now we actually have guidelines as led by Ellis van der Lauw, published now 4 years ago, in order to give advice on how to administer the ketogenic diet in the very young, even when they're breastfed, and indeed whether it be from the initiation, whether the monitoring that's required, and actually the dietary requirements. And what about the other end of the spectrum of the age range in adults? And when we looked at this in 2011, we actually could only find a minimal number of adults and adolescents that had been treated with the ketogenic diet in an open label fashion. But at that time, we demonstrated that the effects were similar to children that were seen in children. And the main reason for discontinuation was lack of efficacy. This is a meta-analysis of observational studies in adults published 2 years ago. And again, demonstrating that there were a proportion that became seizure-free, with also 53% had seizure reduction by more than 50%. And there were adverse reactions, but they were mild. What this study showed was that a more relaxed diet is likely to lead to greater compliance, but lesser efficacy. And in adults, certainly compliance is an issue. What they need to see significant benefit in order to continue in view of the change there would be to their day-to-day life. This is a randomized controlled trial recently published, undertaken in Norway. And unfortunately, they had to stop this prior to achieving the recruitment required for the power of the study in view of the length of time that it had taken to recruit to the study. It took up to 6 years to achieve the number of patients. 277 were assessed for eligibility, 129 did not meet the inclusion criteria, and 73 declined even after meeting inclusion criteria. So in the end, there were 32 patients in the control group and 24 patients in the diet group. And indeed, although they can see that there's some patients who appear to have a dramatic change in seizure frequency on the ketogenic diet, looking at the group data, there was no significant difference in seizure reduction between the two. Certainly, one discussion of implementation in adults may need to rethink the way that we do this, not from the traditional way that we would administer in children. And certainly here you have a suggestion of actually utilizing email management to make it more feasible and effective for adults with a modified ketogenic diet. And here, improving compliance, utilizing supplementation with a Ketocal, a ketogenic diet supplementation, to see more readily whether ketosis can be achieved and indeed whether there can be a benefit. But those treated with the supplement had no greater likelihood of response, but actually significantly more adults remained on the modified diet longer term, so achieving that compliance in the longer term. And we move forward with trying to think of other ways of implementing the treatment. Long have we said, can we give the ketogenic diet in a pill form or a simpler form? And because of the various ways we have perceived the mechanism of action, that doesn't seem to have been possible. However, these studies have demonstrated that medium chain fatty acids, namely decanoic acid, a C10 fatty acid, not only in vitro have shown the anti-epileptic effect much more than sodium valproate, but also another group in London showing that looking at markers of mitochondrial function, namely citrate synthase activity, showing in a cellular model that this can be markedly increased with treatment with C10 decanoic acid. And indeed, the electron micrograph shows the untreated on the left and the treatment on the right, showing a dramatic increase in the number of mitochondria. This put forward as a possible mechanism of action with regard to the anti-seizure effect. Natasha Schuller and colleagues reviewed carnitine profiles with regard to response to the ketogenic diet and demonstrated that acetylcarnitine at baseline was significantly higher in responders, recognizing that carnitine is required particularly in the classical diet for uptake of fat and raw material into the mitochondria. However, Again, the group that had originally been looking at compounds comparing to valproate, this is the group of at the Royal Holloway in London, showed that actually decanoic acid can be seen to have a very similar action to perampanel, namely as a non-competitive AMPA antagonist. And again, another way that it could be anti-seizure in its effect. And we've teamed up with Vitaflow, a nutrition company, to produce a C10-based product that we've trialed in tolerability trials and have some good preliminary results with regard to tolerability. So what about dietary therapies? Where are we now in the treatment of epilepsy? Well, there's no doubt that ketogenic diet therapies are an established therapy in childhood epilepsy. And we've got increasing evidence for extending out that use into adulthood, but also into infant, and utilizing it as early as possible in infancy. We do have some evidence that it can be utilized across a wide range of different syndromes, some more than others, and also at some specific etiologies where we might consider it earlier in the anti-epileptic therapy regime. And as we gain more of an understanding of response, that may enhance our understanding and management of the epilepsis. There is global acceptance. It gives us an enhanced choice of what we can utilize in the treatment, particularly of complex epilepsy, although it does require resource. It requires dietary monitoring and also the ketogenic diet team. And therefore, in adults, this can be a barrier in view of the fact that dietitians aren't necessarily part of an adult team, and that requires additional resource. However, as we move forward, we gain insight into the underlying mechanisms of action, leading into translation of new therapies into clinical practice, where we hope we will move forward over the next 5 to 10 years.
First, sorry not to have introduced you in at the beginning. I don't know. Would you like to do it now?
No, it's okay. Don't worry.
It's okay. So thank you very much for this fascinating talk. It's clear, splendid talk. Very nice. We do have some question. I do have one question first. If a patient is on topiramate for epilepsy, is it a contraindication because it might increase its renal calculi?
I wouldn't regard it as a contraindication. Certainly, we have to be more observant as to whether calculi have developed. In the children, they don't tend to get big stones that you would expect, that cause renal colic. It's more like crystals in the urine. But that aside, we would test urine on a 3-monthly basis for blood. And if we had 3 consecutive positives, then we would organize a renal ultrasound. And I would organize, if an individual was on topiramate, then I would organize a renal ultrasound prior to initiating the diet to check that they had not got any evidence of that in the first instance. So no, I wouldn't regard it as a contraindication. If the topiramate hadn't been of help and the ketogenic diet was, then it would be the first one anti-epileptic I would try and wean. But that aside, I've got children who've continued on both. We've just been careful for monitoring for renal calculi.
Thank you. I have a second question. I think 2 people have asked this question already. Is there any place for ketogenic diet in status epilepticus?
And I would answer yes. And I think increasingly we have been utilizing the ketogenic diet, particularly with refractory status epilepticus. So where they've been admitted to the intensive care unit and where they haven't, whether they've perhaps been put on a barbiturate coma and haven't been able to be weaned from that first time, or whether they failed second-line medication. There are concerns that perhaps, will it be absorbed? How can we administer it? We administer down a nasogastric tube, and therefore utilizing it earlier in status epilepticus is perhaps more advantageous because there's less concern about the fact the gut may have gone into ILAE after a prolonged period on ITU. There gets concerns about gut function. However, it can be given, ketogenic diet can be given parenterally, but I think this may be utilized more frequently when individuals are on a ketogenic diet and require periods nil by mouth. But in the treatment of status epilepticus, certainly we've used it enterally and increasingly it's been utilized both in adults and children.
Thank you. I think you answered this question. I saw it many times. Is there any diet restriction when we start a ketogenic diet? Should we? Yeah.
We don't well, depends how the diet is going to be administered. We, in our clinic, we initiate it as an outpatient unless the child is under 1. We don't fast to initiate the diet, and there's no fluid restriction. In the older we'll say 10 years ago, when it was gaining momentum, there was a protocol, particularly from Johns Hopkins, and this is somewhere that's got an enormous amount of experience, that would fluid restrict to 75% of fluid within gluten diets in the diet. We don't do that. We don't restrict fluids, and we don't fast on administration of the diet. So the only dietary restriction really would be if they've already got a dietary problem. And we can utilize, I mean, if you think about it, yes, it's easier if they aren't, you can administer it as dairy-free, but it's more difficult. You know, if you've got an individual who's dairy intolerant or milk intolerant. But certainly the only, one thing I will mention is that people worry about behavior disorder and being a contraindication to the diet. Behavior disorder per se doesn't. Where individuals have got specific issues around eating, that can be problematic, and not least textures. Some children, particularly children with multiple disabilities, may have problems with specific textures, and that can be problematic administrating the diet.
Okay, another question is if relapse occur after discontinuation of ketogenic diet, should we reinitiate it? Start it again?
Of course, yeah. I mean, when we initiate the diet, you know, we look for a response. And if there's been no response after a 3-4 month period and the diet has been optimized, then we would wean quite quickly. And then people ask, how long do you continue the diet for? And we usually go for no more than 2 years before trying to wean. And 80% of individuals will come off the diet without a problem, even though we've weaned the diet. There seems to be some degree of disease modification. But there are some individuals who, on attempting to wean the diet, do get an exacerbation of seizures. And then we have to weigh up the risk benefit of continuing the diet. And some, you know, yes, we do reinstitute the diet and get benefit again. And they may go longer before we try and wean again. But, you know, we're constantly weighing up the risk benefit to continuing the diet. What are the risk of side effects versus the benefit of actually achieving better seizure control? And I have got, albeit a handful of children, only a small number of children who've carried on for 5, 6, 7 years on the diet because that's the optimal treatment, and they are so much better on the ketogenic diet. When we try and wean it, then they get a seizure exacerbation.
Very good. On another question, is a patient on another approach, on other kind of palliative treatment like vagal nerve stimulation? Can we add a ketogenic diet? Absolutely.
And in fact, there's some data that's almost an additive effect. You know, you get some benefit from the vagal nerve stimulation and then further benefit from ketogenic diet. So being on vagal nerve stimulation, there isn't any real treatment that's contraindicated in administering a ketogenic diet. And certainly you can see additive effects.
I think you answered already this question. I saw it many times. How long should we keep giving ketogenic diet? How long? 3 months, 1 year?
In order to assess for benefit, it usually takes 3-4 months because you need to optimize the diet for that particular individual. If there's been no benefit after that period of time, then it's unlikely there's going to be any benefit longer term, and therefore we would wean the diet. You know, traditionally we've said try the diet for 2 years and then try and wean it if there's been benefit. Some children don't get there, especially some of the children with epilepsy with myoclonic astatic seizures. They may try it for a year and then do they need to continue it, and some can wean at that point. But traditionally we try for 2 years, you know, if they've had benefit, we utilize it for 2 years and then we discuss trying a wean.
Okay. Another interesting question. If we stop ketogenic diet in glutamine 1 deficiency, is there any chance that the seizure became refractory?
You mean in GLUT1 deficiency?
Yeah.
Yeah, I mean, yes. You know, we have children who come to us who haven't been diagnosed and their seizures have not responded to anti-epileptic drugs. And we diagnose the GLUT1 deficiency and they get a much better response to ketogenic diet. So they may be refractory to the medication, but they still may respond to a ketogenic diet. The main reason, I mean, others ask if they've got seizure control with a medication and GLUT1 deficiency, should they go on a ketogenic diet? And I think in young children, the answer would still be yes. In adults, it's more of a discretionary discussion, I think, with the family. But in children, we know that actually they get impaired cognition if they continue to have without benefit. And ketogenic diet, there's some evidence that if you start it early, get response to the seizures, then also their cognitive outcomes are improved. And even those that we've started later, they get much more better cognitive performance if they're on a ketogenic diet than if not. So I think you're not only treating the seizures, you're treating the other neurological manifestations of GLUT1 deficiency when you utilize a ketogenic diet.
Thank you. Another question, too many questions. From your experience, does ketogenic diet alter the plasma level of phenobarbital? It will change, does it change the level of phenobarbital?
We've got no evidence that that indeed occurs, no.
Okay, that's fine. Another question, how is the weaning process of ketogenic diet? Do you switch to normal diet immediately or in slower process? Okay.
It's a slower process and it's usually, it depends what type of diet that they may be on as to how you wean it. On a classical diet, you may reduce the ratio slowly of fat to carbohydrate, including protein. So if they're a 4-to-1 diet, in the first instance, you may go down to 3.75, then 3.5. And how quickly you do it probably depends in some degree on the response they've had and how long they've been on it. So if they've only been on it 3 months and it's had no benefit, you'll probably be able to wean it over a 2 to 3 week period. If they've been on it 2 years and they had a real benefit from the diet, then you're going to wean it over a 3 to 4 month period. An MCT diet, you're probably just going to slowly reduce the percentage of fat as medium chain triglyceride. Sometimes we just substitute snacks to start with a normal snack and then reduce the meals. It may depend from child to child and also on the type of diet that they have been on.
Very good. Another question, too many questions. Another question. Do you have any data on patient being just on ketogenic diet only, not
Yes.
for seizure control, not on anti-epileptic drugs?
Yes. Now, if you're talking about, you know, we regard the ketogenic diet as another anti-epileptic therapy. Some children who we start on it have been on medications in the past and their families have decided it's not been of benefit and we've therefore just started the ketogenic diet. Others, if we see benefit from the diet, then from the dietary therapy, then we slowly wean the other medications because they haven't been as beneficial, just like we would if we had a successful anti-epileptic drug. So yes, you know, they do wean from medication and some children are maintained on a ketogenic diet only in their treatment.
Oh, very nice. Another question I think is good answering. Is compliance to ketogenic diet a concern for you?
What's that, compliance?
Compliance to ketogenic diet. Is it like anti-epileptic drugs?
Yeah, I mean, this is what we tried to study with the Attitudes to Medicine questionnaire, which actually was formulated for looking at compliance with anti-epileptic drug therapy, looking at attitudes to therapy, whether there's concerns or a belief that it was going to work. And there's no doubt there is a relationship of response to positive attitude that it's going to work and that there's a lack of concern about the treatment, suggesting that families adhere to it more if they believe it's going to work and they feel that it's going to be safe. So I think, you know, one thing we can look at is ketones. we look at ketones in the urine or the blood, and they monitor those daily when we're starting the diet and for at least a period of time following. If they're not ketotic, then it's unlikely they're complying with the diet. If they have a degree of ketosis, then they are complying at least to some degree. So most of them do undertake that. And if they're finding it too difficult, then they will declare to us. It's not hidden like you have with the medication. What's interesting is actually those that we see intermittent compliance, so intermittent ketosis, usually related, and I'm not a grandparent, so I'm not going to be rude, but grandparents come round, they feel sorry for them, they give them a sugar biscuit or something, not realizing the importance of the ketogenic diet. So there does need to be a belief across all the family that this is the way to go.
Thank you. Another interesting question coming from Dr. Anyama Dominic from Cameroon. She or he is asking if you know a center practicing ketogenic diet in Central Africa. She or he would like to connect with them.
Sure.
He would like to start some ketogenic diet, yeah.
Sure. Well, I know that there is a very active dietitian who is trying to branch out and communicate with as many centers as possible in Africa from South Africa. That's Kath McGraw. And also, I know they're establishing ketogenic diet in Kenya. And these are two contacts I know. There are other countries, but certainly I could put, Kath McGraw in South Africa would know most of the centers that may be implementing the diet and be able to put them in touch with the appropriate center.
Yeah, thank you. I think you answered, you have already answered this question from Dr. Fawaz Ahmed. Among the contraindication for ketogenic diet, do you recommend to rule out porphyria in all cases? Porphyria.
No, unless there's no particular symptomatology to suggest that, no. The only things that I would do to make absolutely certain there was not a contraindication would be organic acids in the urine, looking for beta oxidation defects and organic acidurias. That would be an absolute contraindication. Many of the other metabolic defects, they will be have other symptoms suggestive of that, and therefore may have been ruled out before, including porphyria. But it's making sure that they haven't got a beta oxidation defect because of the risk of hypoglycemia.
Thank you very much. I think I summarized all questions. All questions. There is no more. Okay. Thank you for this fascinating talk. Thank you very much.
No problem. Thanks very much.
Thank you. Thank you.
Thank you, everyone, for this interesting talk. I think it's now the turn to next talk. I will introduce Dr. Ghaib Al-Jindil. He is a graduate of Baghdad Medical College at 1977 and King's College London Hospital, the UK, at 2007. He's also a senior lecturer and member of teaching faculty of Iraqi Council for Medical Specialization in Iraqi Boards of Neurology. He's board member of ILAE in our executive committee for 2 terms, and he is also, of course, a consultant epileptologist in Iraq. So you can start, Dr.
Thank you, Dr. Reem. Thank you, Dr. Reem. I will start now the lecture about classification of neonatal seizures, and I will receive definitely the questions after the end of this lecture. Hi, everyone. Our subject today is the classification of neonatal seizures based on International League Against Epilepsy 2017 seizure classification. The ILAE Commission on Classification and Terminology recognized that seizures in the neonatal period require special considerations, and therefore a task force was established with the aim of integrating seizures and epilepsies in this age group into the ILAE 2017 classification. The presentation is simply to throw light on the fabulous job of this task force. Definitions. For the purpose of this report, the following definitions are used. Gestational age, which is the most important, time elapsed between the first day of the last menstrual period and the day of delivery, while PMA, post-menstrual age, is the gestational age plus the chronological age in weeks, that is the age after delivery. Conceptional age is the age from conception, that is to say, post-menstrual age minus 2 weeks. The preterm infant is the infant born before, at or before 37 weeks. While the neonatal period is the period from birth up to 28 days, 4 weeks in term neonates, while from birth to up to 44 weeks of PMA, post-menstrual age, and preterm neonates. Well, seizures are the most important common neurological emergency in neonatal period, as you know all. The majority of neonatal seizures are symptomatic and are of an acute illness with an underlying etiology usually. But epilepsy syndromes may present in this neonatal period. Main causes that account for most of the seizures will be shown in the next figure. That is to say, hypoxic ischemic encephalopathy is the main, infarction and hemorrhage, genetic, metabolic, infections, brain malformations, etc. Well, clinical diagnosis of neonatal seizures is difficult, and there's usually poor inter-observer agreement independent of the observer's specialty. The immature state of the motor pathways in terms and preterm neonates may account for some of the difficulty in differentiating seizures from non-epileptic movements. Well, seizure burden is defined as electrographic seizures in minutes per hour. And there is evidence that electrographic seizures or electrographic seizure burden has a comparable effect on the outcome similar to the clinical or electroclinical seizures. The ILAE defines a seizure as a transient occurrence of signs and symptoms, or both of them, due to abnormal, excessive, or synchronous neonatal activity in the brain. Electrographic-only seizures are not included in this definition, the definition of the clinical seizures. Neonatal seizures historically are often categorized as clinical only, electroclinical, or electrographic only seizures. A clinical only seizure without a definite EEG association, an electroclinical seizure coupled with an electrographic seizure, while an electrographic only seizure refers to the presence of a definite EEG seizure that is not associated with any evident clinical signs. The American Clinical Neurophysiological Society has recently defined electrographic neonatal seizure as a paroxysmal, abnormal, sustained change in the EEG characterized by a repetitive and evolving pattern with a minimum of 2 microvolt voltage and the duration of at least 10 seconds. This definition does not require any evident clinical change. Historically, the classification proposed earlier before this classification is included the following: the multifocal clonic, the focal clonic, tonic, myoclonic, and subtle seizures. And this is the usual classification which we are using really in our daily practice. Well, the goal of this report is to propose a classification of seizures in the neonates by the task force that emphasizes the key role of the EEG in the diagnosis and be acceptable to neonatologists, pediatricians, epileptologists, neurophysiologists, and neurologists as well, and linked to 2017 ILAE operational seizure classification or epilepsy classification later on. Next slide shows the proposed approach for seizure classification. And this is the presentation is either clinical suspicion of seizure or critically ill patient. Then by video EEG or integrated amplitude EEG, we will find that there is, when they are without EEG correlates, they are non-seizure episodes, while if they are associated with EEG correlates, then they are seizures. These seizures are of two types, mainly with the clinical signs and without clinical signs. When they are without clinical signs, they are called electrographic only seizures. When they are with clinical signs, they will be one of the following. Two main types, the motor and non-motor. The motor is defined or subdivided into automatism, clonic, epileptic spasm, myoclonic, sequential, tonic, while non-motor into two types, autonomic and behavioral arrest. A third type is unclassified when the picture is not very clear. Well, the clinical events without an EEG correlates are not included in this proposed classification of this task force. As seizures in the neonatal period have been shown to have a focal onset, so a division into focal and generalized seizure is unnecessary. This is the first step and the first difference from the ILAE classification of adult or older children. Then in neonate, of course, the video EEG recording is the gold standard for diagnosis, of course. A proportion of seizures are electrographic only, particularly in encephalopathic and critically ill patients. They are mainly electrographic. Uncoupling may increase after administration of anti-seizure medication, especially phenobarbital. Therefore, this will increase the chance of electrographic only seizure, and therefore electrographic only seizures should be part of the classification. The second step about the aware and unaware, that's the impaired awareness seizures. This is not applicable, of course, in neonates, as it is not possible to confidently and reproducibly assess awareness and responsiveness in this age group, so it is omitted. This is followed by the division into motor and non-motor seizures. In the classification of 2017, focal seizures are determined by the first feature, while seizures in neonates can present with a variety of clinical signs. In the majority of cases, a single predominant feature can be determined. This is the third step, to determine the predominant feature and not the first feature to be registered. This predominant sign may or may not be, of course, the first clinical manifestation. For example, a neonate may present with a focal tonic posturing and in addition have some ocular myoclonus. This can still be defined as a tonic seizure, despite of this ocular superadded myoclonus. With events with a sequence of signs, symptoms, and EEG changes that change at different times have been described as a sequential seizure. And this was added to the seizure types in this age group. Well, of course, several seizure types described in ILAE classification cannot be diagnosed in newborns. For example, sensory seizures. They may appear in a neonate as just electrographic only events. Awareness and responsiveness cannot be accurately assessed in neonate and hence not readily classified, and it is omitted from the typing of the classification. Similarly, somatosensory or visual auras cannot be determined in neonates and so are omitted. And also, and due to the relative low muscle tone and supine position of the newborn, is always lying, the occurrence of a tonic seizure cannot be evaluated clinically without, of course, invasive methods. So again, it is omitted. These seizure types all are therefore not included in the proposed framework, and this was the fourth step. Motor seizure can be further classified using modalities listed in the following table: automatism, clonic seizure, epileptic spasm, myoclonic seizure, sequential seizure types, and tonic seizures, mostly with unilateral or bilateral, and when they are bilateral, may be symmetric or asymmetric. Epilepsy syndromes may present in the neonatal age period, and there's mainly three types: the self-limited familial neonatal epilepsy, the EME, early myoclonic encephalopathy, and Otihara syndrome. Well, as seizure was defined, seizure was defined as an electrographic event with a pattern characterized by sudden, repetitive, evolving, stereotyped waveforms. Evolving is very important, with a beginning and end, which may or may not be accompanied by paroxysmal clinical changes. So no minimum duration was specified as long as there was sufficient demonstration of evolution in the frequency and morphology of the discharge. The exception to the concept evolving are the myoclonic seizures and the spasms, which are associated both with an age correlate that is very brief and not evolving. The age was used to confirm that an event was an epileptic seizure or is not an epileptic seizure. Well, the results, a total of 147 seizures and 156 neonate was reviewed. Demographics are summarized in the following table. The common etiology in term infants was HIE, and in the preterm was the vascular stroke or hemorrhage. This is the demographics of this job. The following table details the seizure types according to etiology, and this we will discuss it now. The most common seizure type was electrographic only, both in term and preterm infants. Most common type is the electrographic only seizures. The most common etiologies of electrographic seizures were HIE and infection. Clonic seizures were typically seen in association with vascular etiologies, term infants only, while tonic seizures and sequential seizures were most commonly observed in genetic etiologies. Myoclonic seizures were seen in the inborn error of metabolism. Well, all seizures in neonate with a genetic etiology had motor manifestation. Automatism and behavioral arrests were uncommon as a dominant seizure manifestation in this age group. In preterm infants, 70% of seizures were electrographic, regardless of etiology. No dominant seizure type was seen for acute metabolic disorders, cortical malformations, and unknown causes, but numbers, of course, were too small for comparison. Well, discussion in the neonate, the development with the limbic system with its connections to midbrain and the brainstem is more advanced than to the cortex. The seizure type is typically determined by the predominant sign, as we said earlier. Predominant feature may provide clues regarding the etiology, and this is the reason why they prefer that the seizure type is the important sign here, because it gives some clues to the etiology. Most neonates with genetic etiologies have tonic seizures or sequential seizures or both, whereas in preterm infants, regardless of etiology, and neonates with HIE and infections present most commonly with electrographic only seizures. Term infants with stroke are more likely to have focal clonic seizures. Myoclonic seizures are associated with inborn error of metabolism. So there's a clue or a relation between the predominant sign and the etiology. It has been suggested that rhythmic discharge of less than 10 seconds duration so-called BIRDS, brief interictal rhythmic discharge, are associated with seizures in the same or subsequent EEG recording. BIRDS are defined as very brief, less than 10 seconds range of focal or generalized rhythmic activity with or without evolution, that are not consistent with any known normal or benign pattern. It has been suggested that definite pairs with an evolution will represent very brief electrographic seizure, while those with no evolution are interictal activity. Final framework of neonatal seizures is this, where there is seizure type, motor, and non-motor, and electrographic. And there's no type of epilepsy here because all the seizures are regarded as focal. So the seizures or epilepsy is epilepsy with focal seizures when it is diagnosed. But we have epilepsy syndromes, and you said that there are 3. These are the etiology, the 6 boxes of etiology, where there is they omit the immune box, which is found in the older children, because no place for immunity is regarded or proposed here, while they add the box, special box for hypoxic HIE in the etiology. So hypoxic includes HIE and other hypoxic events in neonatal period. The structural box includes infarction, hemorrhage, brain trauma, and brain malformation. Malformation are here associated with or put together with the infarction and hemorrhage. There is no evidence at the present time that immune processes play a role in the etiology of this age group, so it was omitted from the 6 boxes of reason. EEG is considered the gold standard for seizure diagnosis in the neonate, but situations when and where it is not readily available is the amplitude, integrated amplitude EEG may be used, although its limitations are well recognized and known. Integrated EEG or cerebral function monitor, CFM, is widely available. Interpretation using patterns recognition can easily be learned by even the rotators, but short seizure less than 30 seconds will not be detected. Movement artifacts are difficult to be excluded or may look like seizures, and non-experts usually are prone to false negative errors. This is the picture for this amplitude EEG or cerebral function monitoring. This is a picture for a normal trace. This is a normal trace. Should we like the look or see the variation in the amplitude indicating sleep-wake cycling. The upper margin, the normal, is above 10. This is 0, 4, 5, 10, 25, 50, and 100. So the upper margin more than 10, while the lower margin is above 5. This is the 5. The lower margin should be above 5, and the upper margin should be above 10, so that to be regarded as normal tracing. And the mean is around 25 microvolts. This is again an example of the very normal integrated EEG. And this is an example of the severely abnormal type of this traces from an infant that suffered a severe asphyxial insult. Very narrow, this is very narrow, and suppressed, it's downwards, band of activity with occasional spikes indicating birth suppression. These spikes are indicating birth suppression, and we see that the lower margin is less than the 5 and the upper margin is less than 10, so it is abnormal tracing. This is the picture for the adult or the elderly, or the, older children, where we find the 3 levels of classification. The first level is seizure classification, focal onset, generalized onset seizure, and unknown. Then the second level is the epilepsy types, focal seizure, epilepsy with focal seizure, epilepsy with generalized seizures, and the third category, that is epilepsy with combined generalized and focal seizures, and the fourth category, the unknown. The fourth, of course, level, or the third level, is the epilepsy syndrome, which is seen in our neonate and infancy, childhood, adolescence, and adulthood. This is on the left side, the comorbidities, while on the right side is the boxes of etiology, the structural, genetic, infectious, metabolic, immune, unknown, all the same as in the neonate, but the immune is omitted, and it is but another type, the HIE put as a separate box. This is the already mentioned, only seizure type, the 3 type, motor and the orthographic, then the epilepsy syndrome, then the etiology. And in conclusion, a new framework is proposed for seizures in neonates in keeping with 2017 ILAE seizure classification, while tailored to the neonatal period. The framework emphasizes the necessity of EEG diagnosis of seizures in the neonate or neonatal period. Seizure can occur with the clinical manifestations, motor or non-motor, or without clinical manifestation, that is electrographic only seizure. The descriptors are determined by the predominant clinical feature and divided, as we said, into motor and non-motor types. This is a direct comparison between the 2 schemes for classification in neonate and adult. We find here the seizure type, epilepsy type, epilepsy syndrome. Comorbidity is the same, while the seizure type here only 3, those epilepsy types here are not included. Epilepsy syndrome is present. The 6 boxes are again 6, but they are by hypoxic. The box is the first, and the immune box is omitted. Well, if I don't have time, but some criticism, there are some suggestions and comments for this classification from worldwide specialists about the task. The task force, before after completing the draft, which is already seen here in my lecture, but this draft under the supervision of worldwide specialists and neurologists and other specialties, and they have some type of suggestions, and I would read these suggestions in my 5 minutes. Suggesting, one of them is suggesting a minimum time for this discharge may probably be more helpful. This is the time of 10 seconds. 10 seconds is not included in the definition of our task force. Why it was written or mentioned by the definition of the American Clinical Neurophysiological Society. Another criticism that from other neurologists, we propose to use the polygraphic video EEG, emphasizing the study of the autonomic functions of the neonate. Other emphasis should be placed clinical classification rather than electrographic video EEG based classification. That is why, because neonatal EEG service is not readily available in many intensive care units of neonate. There's one. Secondly, interpretation of neonatal EEGs is very subjective and mostly restrained due to lack of experience in therapies. And this is a worldwide problem, really. I am not sure if the term generalized onset seizures of the new classification should be eliminated because these are observed, for example, in the epileptic syndromes. This is one comment. Other comment about bears or electrographic only seizures are more easily picked up in the severely encephalopathic infant since they stand out from suppressed or discontinuous EEG, while in the healthier, perhaps more active infant, brief or very focal discharge may be hidden to algorithm or to the eye of the observer. Thus, the classification may be biased to the most severe cases. This is one comment. Other comment is that the first symptoms versus most prominent symptom. This is causing difficulties in practice when looking at videos, as the implications are different. Sequential, this term is rather confusing and will probably end up as default state for seizures which cannot be accurately classified. Automatisms, most such events are not epileptic, so will cause confusion in the absence of EEG. Clinical only events. One inquiry that could we ignore this important section of events in a newborn only because they are not recognized by scalp EEG with all its limitations? It seems convenient to consider adding seizures with the clinical manifestations only, especially when they appear in neonates with interictal paroxysmal activity in the EEG and there is symptomatic etiology none. Among the neonatal epilepsy syndromes, epilepsy with the migrating focal seizure should also be included since it can have a neonatal onset as a fourth type of syndrome. Neonatal status epilepticus, since this document highlights the role of EEG in neonatal seizures, so neonatal status epilepticus will be worth mentioning. To be consistent, please consider using 44 weeks post-menstrual age to define the end of the neonatal period for babies born at any gestational age. I partially agree with the statement that most neonatal seizures are of focal origin. In paradoxine-dependent hyperglycemia, the predominant seizure type will be generalized, myoclonic, as well as an Otihara syndrome due to structural malformations. You may get a clinical generalized tonic-plasm. So, in his opinion, we can have focal, motor or non-motor, generalized, and electrographic as the three major groups to begin with. In the etiology, it will be better to have vascular and structural as separate entities as the prognosis, connotations, and need for prolonged aid may be very different in dysplasia versus hemorrhage and stroke. Well, this is one of the suggestions of one of the neurologists when he put the same diagram, but he put the epilepsy type, seizure types, so the focal and will subdivide motor, non-motor, and electrographic, and this will be focal epilepsy, then the epilepsy syndrome, then the 6 boxes of etiology, and the comorbidity. Thank you.
Thank you very much, Dr. Waeb, for this interesting talk.
Thank you.
I have many questions here for you.
Mm-hmm.
The first question about the classification of the seizure type in neonate. Dr. Mahmoud, he asked why you don't consider the only clinical seizure without any EEG counterpart in the new classification.
Yes, it is one of the criticism and the suggested recommendations which I read already, that we clinical only seizures are really an important part in the neonatal seizures. Yeah.
The other question by Dr. John, he asked, do we classify based on the predominant feature or based on the first feature? I think he means the seizure feature.
Yeah. In the classification of the older children and adults, the most important is the initial feature of the seizure, because it gives a clue to the place when this seizure starts, from where, visual area, say, or frontal region, or temporal, etc. This is in the neonatal seizure, as in the opinion of this task force, is not is taken in another way, that they regard the predominant feature, that it's repeated more and more than not the first one, because it is not important that the place where the seizure will start is not important as the etiology is important. They found a sort of etiology relation between the type of the predominant type of seizures and the etiology. So they took or regard the predominant and go to chronic type, tonic type, sequential types, etc. This is one of the criticism and the recommendations.
It's also, for me, it's not clear what they mean by the sequential type.
Sequential means, again, it's found in the new classification for the adults and older children, when there is different phenomenology and different EEG changes in the seizure. It is not one type of seizure. It is not one form of seizure. It will take few different shapes from one, changing from one to another with a different EEG change. It's called sequential type of seizures, and it is included really in the new classification of the operational seizure classification of 2017. And it is again included in neonates. Yeah.
Very good, Dr. Raed. There is also an interesting question about, she asked about the seizure semiology. She asked Dr. Sousan, do you agree EEG is more important than semiology in seizure localization in neonate, since seizure onset couldn't be discerned most of the time?
Well, in the localization, no, it is not very important really, or not very useful in localization. And the task force did not take this point in consideration. They are not considering the localization. They consider the etiology. So go to this predominant feature. So the EEG is not, well, is not very important really in localization in the neonatal region, in the neonatal age. Definitely the clinical may be even more important.
Yes, thank you very much. Another question he asked about metabolic cause of neonatal seizure are common, such as hypoglycemia, hypocalcemia. Shouldn't these seizures be generalized rather than focal?
Well, hypoglycemia and hypocalcemia, these are metabolic changes, and they are usually considered may be related really with the generalized seizure sometimes. But the presence of generalized or focal seizure is a debate in this age group. This task force did not consider the generalized seizures, while really, in my opinion, for example, we have to consider it because we have myoclonic. In Atihara, we have tonic seizures, are generalized or focal, and we have in EME, we have the myoclonic, which are generalized. And say in pyridoxine deficiency seizures, they are usually generalized, and even the EEG picture is a classical 3-cycle. So really there is generalized seizures, but the task force really did not consider this. But there are some objections from other neurologists. Really, what I did in my lecture is to take the opinion of the task force and project it to you, and then I took the recommendations and the suggestions or the objections of worldwide neurologists to this scheme of classification. And this scheme of classification is still really in the progress. I think for 2 weeks I received an email that they end and the final draft of this classification will be pushed to epilepsy in a matter of 1 week or say. So we wait for this final version in a matter of few weeks, I expect.
Excellent, Dr. Waib. There is also a lot of interesting question for you. Also she asked about, could you mention example for subtle seizure?
Yeah, subtle seizure is one of the older classifications of neonatal seizures. We have classifications of neonatal seizure by Wolf 1997. He put the subtle seizure, the first one, then the clonic seizure, the tonic seizures, and the myoclonic seizures. And this is very practical, really, in our daily practice. Subtle seizure means when you have some changes in, say, an eye closure, then face deviation, then movement of one hand, so some sort of remote changes in different places of the body, say sometimes even apnea, maybe some sort of this subtle seizure. There are seizures which are not very clear to the eye, but they are seizures. This subtle seizure is omitted in the new classification and even substituted by other types, say automatism was one part of this subtle seizure, and sequential may be one of this subtle seizure. There are two type seizures, in addition to the classical, to the spasm, generalized spasm. So there are three with the older three, that is tonic, clonic, and myoclonic. So there are now 6 types of neonatal seizures.
Yeah, a continuation for the same question about the subtle seizure. She asked where to put apnea in the classification, and what is the most common neurological etiology for apnea?
Well, apnea is put in the, really it was one of the, in the subtle seizures first was regarded, and one of subtle seizures. And now in the new classification, it may be not very easy to put it. It is not clonic, it is not tonic, it is not myoclonic, it is not sequential, maybe part of a sequential when it is associated with other seizures. But it was one of the, that's why I believe that subtle seizure, in my opinion, is an important type or important name for neonatal seizures. Well.
Yeah. Another question about also sequential seizure. He asked, what's the difference between sequential seizure and migratory?
And the migratory is one type. Say it is migratory clonic or migratory myoclonic. It is myoclonic, but it's migrating from left hand to the left leg, to the right hand, to the right leg. It is one type. The sequential, no, it is not one type. It is different types. Maybe clonic here, then tonic, then it is a spasm. So it is a changing shape and changing type of seizure. And some people regard it as multiple seizures, but this task force put it as one seizure under the name of sequential seizures.
Could it be a localization, maybe migratory from the right to the left? It could be also named as migratory seizure?
Yeah, migratory, it may be from the right to the left. Yeah. Although in the neonate, the communication is not very mature, but there are, yes, I think so.
Mostly in children. Yeah. Another question he asked, how would a non-motor seizure in a neonate present? I think we answered this.
Yeah, two types of non-motor seizure. That is the autonomic seizure and the behavioral arrest. Two types, behavioral arrest and autonomic seizures. Both are non-motor seizures, while the motor seizure are 6 types, as we say before. Both of them are the clonic seizures on one side, and on the other side is the electrographic only seizure.
Okay, very interesting. There is also a practical question from Dr. Zahra. She asked, when you prescribe vitamin B6 and folinic acid in a neonatal seizure?
No, when we consider, no, when we expect pyridoxine 6 deficiency seizure, we have to use it. The recommendation is that in any type of refractory neonatal seizure, you have to put or to give B6 or folinic acid. And you know, pyridoxine, the seizures are usually very early in presentation. They start from the first hour. Even they may start from the intrauterine life. There is some seizure in the intrauterine life of this neonate, and it will start. So when we expect this type, we have to give vitamin B6 or folinic acid in high doses sometimes, because you know B6 or pyridoxine is needed for the synthesis of GABA in the neonate, which is very important again for the neonate, since GABA, you know, as you know, is not inhibitory, it is excitatory in the neonatal period, and is very important for maturation of neurons in the neonate.
Okay. Another good question. She asked about the classification of seizure in the neonate. She mentioned, what about if she did only one EEG and it was non-conclusive? Should we do another EEG to classify this as only clinical with no finding?
This is a very important question, because it takes attention to the truth. It is not a single EEG. In this classification, we are not using a single EEG. We are using a video EEG study for hours or even for days to go or to get this classification. A single EEG may give us any result. We have to be, if we have no video EEG, we have to repeat this EEG again and again sequentially so that we can get a better result. One point is very important, really, is that in the EEG, when it is single or when it is not very sequential or when we have no video EEG, we will depend really on the background, on the assessment of the background of the EEG. It is very important. A normal background in a neonate tells you a lot about the health of this neonate. And it is even more important and more useful for the clinician than the EEG, which shows you some paroxysmal changes here or there, say pairs or like that.
A question about the classification again. There is too many questions about classification. It's a really interesting topic. He asked about why it's only focal again. Why we don't include generalized seizure in classification?
Yeah, it is not my opinion. It is the opinion of the task force, which I just, you know, put to in front of you the details of this study of the task force. I believe that we should have to put generalized seizure, because you know we have myoclonic seizure, we have pyridoxine deficiency, etc. In the front, in one part, and we put the focal seizures in the other part when it will contain the focal seizure, which are said now, motor and non-motor and electrographic seizures. I believe that generalized seizures are very important to be included, but I just show you the task force job.
Okay, great. Another question, what are the definition of electrographic status epilepticus in neonate?
Status epilepticus neonatal status is when you have abnormal in more than 50% of your recording. If you do a record for 1 hour, you find more than 50% or more with abnormal EEG. This is suggestive for neonatal status epilepticus. And again, this is one of the criticism in this task force job, because they did not really point to this point of status epilepticus in a neonate.
Okay, last question, but not least. What about the prognostic value of this classification and therapeutic consideration?
It is really the important point for this classification is the prognosis, because when it is myoepilepsy, then it is will be myoclonic will be for important error of metabolism, and what is usually there is poor prognosis, and when there is tonic epilepsy or sequential may lead you to some structural changes, which again may give you some sort of prognosis. So it will give you some idea about the etiology. Then the prognosis will be according to that etiology. Sometimes everything is normal. You go to the benign conditions when benign neonatal familial epilepsy, or you go to fifth day syndrome, which is now regarded as seizures and not type of epilepsy, or even you may go to sleep myoclonus of normal sleep myoclonus of a neonate. So it depends on the etiology, which is suggested then by this classification.
I think there is a comment by Dr. Fatma Abdallah. She just tried. She mentioned it's necessary to have corpus callosum myelination, which is not completed during infancy, in order to have generalized seizure. Maybe that's why it's not included.
Definitely, you are very right. The problem in the neonate is that interconnection between the two hemispheres is not very mature, this first. Secondly, the arborizations to the brain stem and the points is more mature than to the cortex. I mean, caudally is more mature than it cephalically. So that we have some sort of changes of unusual presentations of seizures in the neonate. And this point of corpus callosum agenesis may be very important, definitely. That's why in preterm infants, we never have even the generalized seizures. No generalized seizures are seen in the preterm infant. In term infants, we will find these seizures, say myoclonic or by reduction deficiency, etc.
Thank you, Dr. Ghaib. It's really very interesting to be with us today. We don't want to leave you. We don't want to let you talking. It's very interesting talk. Thank you very much for that.
Thank you for you, and thank you for Dennis and for all of you for this nice chance to present this subject. Thank you very much.